Good afternoon, everybody, and welcome to what I believe is our last webinar in the series of Eyes Wide Open, and we are very happy to have you join us this afternoon. With us for our last webinar of the series is Dr. Kieran Moore, joining us from the KFL&A Health Unit in Eastern Ontario, so we're very pleased to have Dr. Moore with us today. Just chatting briefly with Dr. Moore before we started, he brings a really rich experience and a breadth of expertise to the discussion today. Formerly an emergency physician and a coroner in the Brockville area, he's now bringing his expertise to the area of public health and his role as Associate Medical Officer of Health. And so he is marrying a lot of different disciplines, and he's going to be able to give us a great vantage point today as he talks about how we can develop and what needs to be considered in developing a surveillance system for narcotic use here in Canada. So a warm welcome to you, Dr. Moore, and I'll turn it over to you now with the caveat that our lines are muted as participants, but if you do have a question, Dr. Moore will be taking questions and answers at the end of our time together. And this is being recorded, so without further ado, Dr. Moore, welcome.
Well, thank you very much, and thank you, Michael Parkinson, for the invitation to speak here today. The topic is building safety and surveillance into narcotic use. I'd like first, as a disclosure, that I have not received any support from pharmaceutical corporations. And the findings and conclusion represents those of myself and not necessarily representing the official position of KFLA Public Health. Most of what I'm speaking here today is a summary of a meeting that we held locally in March 2012. So last year, and we came together as a medical community when the announcement was made about the conversion of OxyContin to OxyLeo, and we wanted to educate all of our physicians, nurse practitioners, healthcare workers regarding that transition, the reasons for it, as well as potential repercussions. And we had over 100 people attend the health unit, and we had great presenters like Dr. Roger Skinner, who presented a summary of a local inquest that was held and the recommendations from the jury. We had presentations from Dr. Rupa Patel, who talked about safety in practice and her practice at Kingston Community Health Center and how she incorporated screening, and basically had a very significant population that had high use of narcotics and how she improved upon that care. Dr. Meredith McKenzie provided insights into narcotic management as well, and Dr. Scott Duggan was an anesthetist that specialty in chronic non-cancer pain also presented, as well as Sherry Allen, who's a pharmacist, and talked to us about conversion levels. Brian Schwartz, I have to acknowledge, worked with me on the emergency department surveillance tools that we'll be talking to you about later. So thanks very much to this group who helped frame some of the discussion that I'll be presenting to you later. My core objectives, number one, is to describe how we can integrate safety for narcotic use in medical care, and that's from recommendations from over 100 attendees at our meeting here in KFL&A. Discuss population-based data sources for narcotic surveillance, so how can we improve the ongoing systematic monitoring of drug use in our community, and I've clearly outline the importance of that. Discuss the data limitations and timeliness, and review what data can help at a local, so within your practice, regional, provincial level in Ontario. And I have had the pleasure of listening to several other presenters, and I'm going to highlight just some of the epidemiology of narcotic use in Canada. I think we're all aware that Canada is number one, something we should not be proud of in terms of our per capita consummation of opioids. Ontario has the highest rates of narcotic use in the country. There's been a 900% increase in the number of oxycodone prescriptions written in the last 20 years. And I refer you to some great literature on this, in particular the United States General Accounting Office report of December 2003 on OxyContin abuse and diversion efforts, efforts to address this problem, which outlines basically the genesis of this increase in prescribing from 1996 onwards and the strategies used by pharmaceutical companies to increase prescribing of their medications. And each year, 300 to 400 people die in overdose involving prescription opioids. And recently, that's overtaken road traffic accident deaths in Ontario. And of all the opioids, the most commonly implicated now is oxycodone as the direct cause of death. And I'll review some of that data. From a public health approach, so it's very important to define the epidemiology, what we're dealing with, then to identify risks and protective factors on a population basis. Develop and test strategies. Part of these strategies are building safety into your practice, building surveillance systems that can help us monitor, and then ensure widespread adoption. So I'm going a little bit ahead of myself, but how can we incorporate quality improvement plans that particularly strive to improve narcotic prescribing in every family practice in Ontario? Again, I'm just further epidemiology. Gomez in 2011 had a great article looking at geographic variation in prescribing in Ontario, and also discussing opioid-related mortality. She investigated the relationship between the number of opioid prescriptions and the opioid-related mortality. And there's a direct relationship, which I'll show you. And we're able to show geographic variation as well. And I'll show you that map coming up. So here is, on the x-axis, the age and sex-adjusted opioid-related mortality rate. So the higher you go up, the higher the mortality rate. On the y-axis is the number of prescriptions. So there's a direct linear relationship between the number of prescriptions we write and the number of opioid deaths. It tells us that what's driving deaths in Ontario is the prescribing of it. So our drugs must be getting diverted, and our coroner revealed to us 30 to 40% of our prescriptions in our practices, those opioids are getting diverted to the street and ending up with accidental overdoses, and or those to whom we're prescribing are dying needlessly from accidental deaths. So it's a linear relationship. And when you look across the province, the prescribing rate does vary. And I'm sad to say, over in the Lennox and Addington area at Kingston, that we have one of the highest prescribing rates. You can see it's around 7,000 prescriptions per 10,000 eligible OPD clients. And Thunder Bay, Sudbury, North Bay, Peterborough area, Niagara clearly have the highest prescribing rates. And sadly enough, our death rates from opiate mortality correlate directly, in particular in our area and in the north. And the coroner brought this data to us. The deaths are not coming from the cancer care sector. Problems are related to the treatment of chronic non-cancer pain when they do their investigations. And there's a significant illicit diversion of legally obtained through prescriptions of opioids, and improperly prescribed opioids or improperly utilized opioids. And that came consistently through when our coroner investigated these accidental deaths. Prescription opioids are the predominant form of illicit opioid use. And that was quite startling to the 100 or so physicians in our area that attended, that we are associated with the misuse, that a high percentage of our prescriptions are getting diverted to the street or in combination with other drugs, and or being used by families and friends. And this is now also well documented in the literature. How did it happen? How did we become number one? Since prescription of opioid control measures are lax and inconsistent across Canada, this approach needs to be considered. It's basically because we didn't have any prescription monitoring system. We didn't have the surveillance system set up to monitor this sudden rise, and hence have prevention and control strategies. And that's what's happened here, and that's what we need to tighten up. And hopefully over the next half hour I'll be able to describe to you some ways of monitoring and providing feedback loops to decision makers. As well, there were patterns in those seeking addiction help. So the Center of Addiction Medicine in Toronto observed increasing patient visits for oxycodone control. Total number of admissions for opiate addiction grew from 78 in 2001 to 166 in 2004. And oxycodone addiction went from 3.8% of admissions to 55.4% of admissions. If we had surveillance systems in place back in the late 90s, early 2000s, we clearly would have been picking up on the deaths earlier. We would have been picking up on the complications of the use of oxycodone and the higher admission rate for addiction. And we would have been questioning the literature out there that was telling us that only 1% of patients provided these medications had a risk of addiction, when the literature now shows that over 35% have a high risk for addiction. And from the coroner data, you can see rise in 2002 of 35 deaths, 2003 of 47, 2014 58, predominantly accidental deaths, not purposeful, not suicide. And if we had surveillance systems monitoring that, the alarm bells should have been going off. When you triple your death rate in 3 years, those surveillance systems should have been placed to inform decision makers that we need urgent attention. And it is only when OxyContin was changing its formula to Oxyneo that as a medical community we really started to react. And the other pattern we should be watching is the fentanyl pattern, which is going up linearly as well. Of note, morphine, heroin utilization in the community and their associated mortality is remaining fairly flat. So it's really the introduction of a new, highly addictive formula that caused this rise in deaths in our community. Another way of looking at this data is these frequency histograms, and it's just as informative now going to 2011 in this graph of the persistent high rise in deaths from OxyContin, maintaining at around 160 deaths a year in 2011, although that data was incomplete. And if we look at fentanyl, again, it's a worrisome pattern for fentanyl use going linearly higher from approximately 30 deaths in 2005, almost doubling in 2008, and now tripling by 2010. So two significant drugs that we have to keep an eye on in the community. And here's just looking at, if we had surveillance systems in place, baseline aberration detection, we would have seen this sudden rise in oxycodone deaths, and as a community, medical community, we should have been reacting. Whereas most other death patterns from morphine, heroin, were quite linear and at a baseline rate. So, questions many in our community are asking is this really a problem? There were 350 opioid deaths in 2008. Well, what does that mean? Well, that year, there were around 125 deaths by drowning. If you think back on the educational systems we put in place to prevent drowning, education of children, provision of education and swim lessons within schools and after schools, of the education pathways we have in place to prevent drowning. And last year there were less than 350 deaths of drivers in motor vehicle accidents in Ontario. And I'll try to compare and contrast the safety systems we have in place for motor vehicle accidents and what we have in place for opioids, now that the death patterns are similar. If you look at the death rates in Ontario, this goes from 1975 through to 2008, it's been remarkable progress. Fatality rate per 10,000 licensed drivers is one of the lowest in North America. And kudos to Ministry of Transportation and the engineers that have designed better cars and the police that enforce our regulations, and organizations like Mothers Against Drunk Driving that have really pushed safety in motor vehicle accidents. And now we have one of the lowest fatality rates in North America, if not in the world. And that's because we built safety, we built surveillance, and we prioritized traffic safety for our community. We realized that there's a business case for it, and there's a necessity to have improved safety. And so I like using a rule of ease, where you engineer safety into the car. So you look at seatbelts, you look at incorporating airbags, specific design of the vehicle, you crash test it, you enforce safety through ticketing for high speeds or for alcohol consumption, ticket when people don't wear their seatbelts or are texting, etc. And we bring in new laws, and we continually monitor our safety provisions and our safety enforcement. If necessary, just like this new bylaw to prevent use of our smartphones, we bring them in when required. And we've done tremendous work in terms of modifying the environment, so road design, intersection design, appropriate signage, barriers, warnings. We've looked at the economic sides of this in terms of maintaining and promoting business. There's an economic side for the use of modifying the environment, of course, and safety. And we've educated our public. We've had significant enhancements of education and graduated licenses, a whole change in social pressure regarding consumption of alcohol. We need the same social pressures regarding increased utilization of any driver distraction methods. So you can apply this rule of ease, engineering, safety, enforcement, environment, economic, education. You should be able to apply them to narcotics.